Welcome to KJR SummaryCast. SummaryCast provides audio summaries of KJR articles created using an in-house AI tool with editorial or author review. For full details, please refer to the original article. Welcome to SummaryCast.
Today, we're looking at a paper from the March 2026 issue of the Korean Journal of Radiology. The title is Prognostic Significance of Pre-Treatment 18F ALF-NOTA-FAPI-04 PET-CT in patients with recurrent gastric cancer undergoing combined PD-1 inhibitor and chemotherapy.
That is a long title. Let's break it down.
Well, at a high level, it's about using a specific type of PET scan to predict which patients with recurrent gastric cancer will benefit from a modern combination of chemotherapy and immunotherapy.
Okay, so the core problem is clear: recurrent gastric cancer.
Exactly. After surgery, if the cancer returns, the prognosis is often dismal, with median overall survival under a year.
And the current approach is chemoimmunotherapy, combining a PD-1 inhibitor with chemotherapy.
That's right. It has improved outcomes, but it's not a silver bullet. Only a subset of patients derives a meaningful benefit.
Which is the classic challenge. How do you predict who is in that subset before you start an expensive and toxic treatment?
Precisely. You need a reliable prognostic and predictive biomarker.
The standard imaging tool for this kind of question is often FDG PET-CT. Why not just use that?
The authors point out that FDG PET-CT can be a bit of a blunt instrument in gastric cancer. Its utility is constrained by histological heterogeneity and, non-specific physiological uptake.
So you get a noisy signal. You need a more specific tool.
Which brings us to the agent investigated here, 18F ALF-NOTA-FAPI-04. For simplicity, we can refer to it as 18F-FAPI-04. It targets something called fibroblast activation protein, or FAP. FAP is a protein that is highly expressed on cancer-associated fibroblasts, or CAFs.
And CAFs are a key component of the tumor microenvironment, the TME.
You nailed it. And these CAFs are often bad news for the patient. They play a critical role in immunosuppression and tumor progression.
So the operating theory is, if you can image these FAP-expressing fibroblasts, you're essentially creating a map of the immunosuppressive landscape of the tumor.
That's the hypothesis. A lot of FAP signal might indicate a tumor microenvironment that's inherently resistant to immunotherapy.
An immunologically cold tumor. So how did the researchers test this?
They conducted a retrospective cohort study. They identified 51 patients with recurrent gastric cancer after they'd had a gastrectomy.
And all these patients were about to start chemoimmunotherapy?
Yes, and here's the key part of the design. All 51 had a baseline 18F-FAPI-04 PET-CT scan within 14 days before initiating that treatment.
A pre-treatment snapshot. What metrics were they extracting from the scans?
They looked at three main semi-quantitative parameters. First is SUV max, the maximum standardized uptake value.
The classic hottest spot metric.
Right. But they also looked at two volumetric parameters, which are often more robust. FAPI-avid tumor volume, or FTV.
Okay, so the total volume of FAP-positive tumor.
Exactly. And the third was total lesion FAP expression, or TLF.
How is TLF different from FTV?
Think of TLF as a composite metric. It's the FTV multiplied by the mean SUV within that volume. It captures both the extent and the intensity of the FAP expression across all lesions.
So it's a measure of the total body FAP burden. Makes sense.
Precisely.
And what was the primary endpoint? How did they define a successful outcome?
The primary endpoint was what they called durable clinical benefit, or DCB.
Define that.
DCB was defined as achieving a complete response, partial response, or stable disease that lasted for more than 6 months after treatment.
And the alternative was non-durable clinical benefit, or NDB, for those who had progressive disease or died within 6 months.
That's right. So it's a clinically meaningful endpoint, not just a snapshot of tumor shrinkage.
Okay, so the results. Did the FAPI metrics actually differ between the DCB and NDB groups?
They did, quite significantly. The 30 patients who achieved DCB had consistently lower FAP uptake on their baseline scans.
Quantify it.
Well, the median TLF in the DCB group was 65.2. In the NDB group, it was 476.6, a massive difference. The p-value was less than 0.001.
Wow, that's a huge separation. What about FTV and SUV max?
Same story, just slightly less dramatic. FTV was also significantly lower in the DCB group, with a p-value of 0.001. SUV max was lower too, with a p-value of 0.039, so all three metrics pointed in the same direction. Less FAP signal predicted a better, more durable response.
Of those three, which one was the best predictor? Which had the highest diagnostic accuracy for DCB?
They ran a receiver operating characteristic, or ROC, analysis to answer that. TLF came out on top. It had an area under the curve, or AUC, of 0.80.
That's quite good. A value of 0.80 suggests a strong predictor.
It is. FTV was next with an AUC of 0.76, and SUV max was last with an AUC of 0.67. There's a clear trend where the more comprehensive volumetric measures outperform the simple peak value metric.
So the total fat burden, TLF, was the best at separating responders from non-responders. Okay, that's the primary endpoint. What about the secondary endpoints? Survival.
They looked at both progression-free survival, PFS, and overall survival, OS.
And how did the FAPI metrics perform there?
They stratified patients into high and low groups based on the median values for SUV max, FTV, and TLF. In the univariable analysis, having a high value for any of the three parameters was significantly associated with worse PFS and worse OS.
That's a strong signal. But the crucial test is the multivariable analysis. When you account for other factors, do these FAPI metrics hold up as independent predictors?
Exactly. And this is where the story gets really interesting. For progression-free survival, after adjusting for other variables, only one metric remained an independent predictor.
Which one?
TLF. A TLF value greater than or equal to 188.88 was associated with a hazard ratio of 7.29.
A hazard ratio of over 7? So patients with a high total FAP burden were more than 7 times as likely to have their disease progress at any given time point. That's a very strong effect.
It is. A p-value of 0.001. It's a remarkably clear result.
And what about overall survival?
For OS, it was slightly different. In the multivariable analysis, it was FTV, the FAPI-avid tumor volume, that emerged as the sole independent predictor. A high FTV was associated with a hazard ratio of 5.16 for death.
Also a very high number. So to recap, high total FAP burden, or TLF, independently predicts earlier progression, and high FAP positive tumor volume, or FTV, independently predicts earlier death. The volumetric metrics are carrying all the prognostic weight.
Precisely. The simple SUV max metric, while significant on its own, lost its predictive power once you accounted for the volumetric measures.
Before we get into the why, was there any direct comparison to the old standard, FDG?
There was. A small subgroup of 16 patients had also undergone an 18F-FDG PET-CT scan within a week of their FAPI scan.
A head-to-head comparison. What did that show?
Two key things. First, sensitivity. The 18F-FAPI-04 scan identified recurrent gastric lesions in all 16 patients. The 18F-FDG scan failed to detect lesions in 4 of those cases.
So a 25% failure rate for FDG in this small sample. That's non-trivial.
Definitely not. Second, uptake intensity. In the 12 patients with matched lesions, the FAPI-derived parameters, SUV max, FTV, and TLF, were all significantly higher than their FDG-derived counterparts, with p-values of 0.002 or 0.001.
The signal is just stronger and clearer with FAPI.
Much stronger, which supports the idea that it's a more robust tool for this specific clinical question.
Okay, so let's get to the biology. Why are these volumetric FAPI metrics, TLF and FTV, such powerful predictors? It's more than just more tumor is bad, right?
It seems to be. The authors argue that it's about what these metrics are actually measuring. SUV max reflects the single hottest voxel. It could be influenced by focal inflammation or just sampling bias.
It's a point estimate.
Exactly. But FTV and TLF quantify the total functional mass of these fat-positive cancer-associated fibroblasts across the entire body. It's a global assessment of the tumor stromal burden.
And that's mechanistically important because a high stromal burden full of these CAFs is what creates the immunosuppressive tumor microenvironment.
You nailed it. These dense fibroblast networks act as a physical barrier, preventing T cells from infiltrating the tumor. They also secrete all sorts of cytokines and chemokines that actively suppress the immune response.
So a high TLF or FTV on a baseline FAPI scan is essentially a picture of an immunologically cold niche, one that is pre-programmed to be resistant to PD-1 inhibitor therapy.
That's the interpretation. The FAPI PET-CT is providing a non-invasive, whole-body biomarker of this treatment-resistant biological state.
That's a compelling story. But what about the cases that didn't fit the pattern? Were there patients with low FAPI uptake who still did poorly?
A great question, and yes. The paper notes this as a point for further analysis. They observed that early disease progression did occur in a subset of patients with low baseline FAPI uptake.
What's the proposed explanation for that?
It appears to be related to the specific sites of metastases. These individuals often presented with distant metastatic involvement, for example in the bones or peritoneum at the time of recurrence.
So the idea is that an aggressive, site-specific disease phenotype might override the global FAP-based quantification.
That seems to be the thinking. It underscores that even a powerful imaging biomarker like this has to be interpreted within the full clinical context, including where the metastases are located.
Which is a crucial point for any application in practice. Okay, let's talk limitations. This can't be the final word on the topic.
Of course not. The authors are upfront about several limitations. First and foremost, it's a single-center retrospective analysis.
And the sample size is relatively small at 51 patients.
Right, which can limit statistical power and the generalizability of the findings. The cutoff values they identified for FTV and TLF would need to be validated in a larger multi-center cohort.
What else?
The treatment protocols weren't standardized. The specific chemotherapy drugs and immunotherapy dosing were individualized based on clinical conditions.
That's a significant confounder. The heterogeneity in treatment could have influenced the outcomes and muddled the association with the FAPI metrics.
It's a classic challenge of retrospective research. Future studies would need to be prospective, with protocol-driven therapies to minimize that noise.
I also saw a note about using midpoint imputation for 5 patients whose exact time of death was unknown. That can introduce bias into a survival analysis.
It can. So all these factors mean we should view these results as very promising but preliminary. They establish a strong hypothesis that now needs to be tested more rigorously.
Okay, so let's land this. What is the bottom line take-home message from this paper?
I think the bottom line is that pre-treatment 18F-FAPI-04 PET-CT, and especially its volumetric parameters, TLF and FTV, appear to be very promising non-invasive biomarkers for predicting clinical outcomes in patients with recurrent gastric cancer undergoing chemoimmunotherapy.
It offers a potential tool for risk stratification before treatment even begins. In practice, that could help guide therapeutic decision-making, perhaps identifying patients who might need alternative or more aggressive strategies from the outset.
And it highlights a broader shift in oncologic imaging, the power of targeting the tumor microenvironment, not just the cancer cells themselves. This provides a window into the biological landscape that governs treatment response.
A very clever approach to a difficult clinical problem. We'll have to watch for the prospective validation studies.
We will, and that's our summary for today.
Thanks for joining us on SummaryCast.